Virtus Medical has pioneered new technology to treat patients with central canal lumbar spinal stenosis. The mild, minimally invasive lumbar decompression procedure is guided fluoroscopically and can be performed with local MAC or managed anesthesia care. After being identified as a candidate for the mild procedure, the patient is positioned prone on a radiolucent table. A bolster may be utilized to facilitate opening of the treatment site. C-arm or other X-ray fluoroscopy is utilized to assess positioning and to assist with visualization throughout the procedure. The contralateral oblique fluoroscopic view will be the primary working view for the procedure, but verification of medial lateral positioning under the lamina will be assessed by an anterior-posterior view. Lateral fluoroscopic views may also be utilized to confirm depth, particularly when performing the epidurogram. An epidurogram utilizing a myelographically compatible contrast media is performed on the site of the treatment, providing a fluoroscopic visual landmark for the physician. When utilizing the fluoroscopy in a contralateral oblique view, the contrast media highlights the epidural space, which allows for identification of the hypertrophic ligamentum flavum. This fluoroscopic view also allows for the thickest visualization of the lamina, creating a posterior working zone. Instruments should not be placed beyond this visual landmark. Additional contrast media can be added to the epidurogram throughout the procedure to assist in maintaining visualization of the working zone and to assess the amount of decompression being performed. Next, the interlaminar space is identified fluoroscopically, and the guiding portal and inner trocar are inserted percutaneously and advanced along a desired trajectory utilizing direct fluoroscopic visualization. The inner trocar is removed, leaving a hollow access portal into the interlaminar space. The portal is secured against the skin surface by the mild backplate, and the accessory guide is placed over the portal, limiting the forward motion of the working instruments. This portal will allow percutaneous working instrument access to the lamina and the ligamentum flavum. The bone sculptor may now be advanced through the access portal to the free edge of the lamina and can be rotated to sculpt both the superior and inferior lamina. The bone sculptor removes small pieces of bone, opening up the interlaminar space and providing better access to the hypertrophic ligamentum flavum. The instrument is removed after each pass for cleaning. The tissue sculptor can now be advanced through the portal and under the lamina into the dorsal aspect of the hypertrophic ligamentum flavum. The specially designed sculpting tip allows the device to debulk the ligamentum flavum by removing the collagen-laden posterior portion of the ligamentum while leaving the healthy ventral fibers of the ligament intact. These ventral ligamentum fibers remain as a protective zone to the epidural space. When the trigger of the tissue sculptor is engaged, the outer cannulated cutting surface closes over the two cutting jaws, capturing and cutting a piece of the ligament. The device is then retracted from the portal, and the specimen is ejected from the device with the thumb trigger. This process is repeated as often as necessary to debulk the hypertrophic ligamentum flavum, decompressing the spinal canal. Decompression can be visually confirmed by the operating physician through noted changes in the epidurogram and contrast flow. The injected contrast media should flow more easily into the epidural space, which would appear to have a larger, thicker, straighter area when visualized in the contralateral oblique view. After the operating physician has assessed that there is adequate decompression, the accessory guide, mild backplate, and portal are removed, thus leaving nothing behind. The portal sites can be closed with a steri strip, with no need for sutures. If required, the entire process may be repeated on the opposite side of the spinous process to provide bilateral decompression of the